All right. Now that is it. And let's look at what you call apheresis donation. So apheresis is correction of specific blood components by returning the remaining components to the donor. And apheresis can correct platelets, plasma, leukocytes, RBCs, and stem cells. All of them can be corrected via apheresis. This apheresis enables large volume correction and is the only effective method for leukocyte and stem cells. We cannot correct stem cells like all blood, in all blood. It is not possible. And we cannot correct, yes, we can correct leukocyte in all blood, but it is not possible to separate it from all blood. So in most systems, the machine that we use, they can only separate RBC, platelets, and plasma, but they cannot remove leukocyte from there. So we use only apheresis machine to correct these leukocytes. So apheresis, of course, is a machine that corrects blood, and that is wanted, like one unit, maybe one component, like platelet apheresis, RBC apheresis, plasma apheresis, and so on. So, and also leukocyte apheresis or granulopheresis. So now, let's talk about platelet apheresis. So platelet apheresis is a unit that is collected by machine. Usually it is large amount, comparing to the donor, to the what we call random donor platelets. So it is equal to 6 to 8 random donor platelets, providing therapeutic dose for most adults. So donation interval between one donation and the other is at least 2 days, maximum twice a week, or 24 times per 1 year. So that is the maximum times someone can donate platelets through apheresis. At least twice, at least 2 days difference or interval, and maximum twice a week. That is for platelet apheresis. And when you want to compare it with a random donor platelet, it must be at least 6 units that are pulled together to produce one apheresis. So having said that, in fact, when we talk of random donor platelets, it means that this is a platelet amount, platelet units that is corrected or that is prepared from whole blood after correction, of course, within 8 hours of correction. And without putting it in the fridge, we have to prepare platelets from the whole blood, and that platelet unit is called random donor platelets. So if the patient is taking aspirin, of course, they should be differ for 48 hours differ after. And if the patient is, of course, taking aspirin, so we have to give the patient 48 hours deferral. And you can give 14 days deferral or 2 weeks deferral if the patient is taking Plavix or lead. This should be also indicated. If the donor has donated whole blood, or if RBC was lost during the donation or prior, this will require 8 weeks deferral for recovery. So we don't correct plasma apheresis if the donor donated whole blood before. Whole blood maybe for the whole blood, we have to give 8 weeks deferral, as you know. For whole blood is 8 weeks deferral. And for RBC, 1 unit is 8 weeks deferral. If it was double unit of RBC, it should be 16 weeks deferral in order to come for platelet apheresis. So, platelet count is required if donations are less than 4 weeks apart, with maximum of at least 150,000 platelets per microliter. So this is always done, especially when donation of platelet is frequent. It's frequent. Sometimes, of course, we need to know how much platelets, because if it is less than 150, it is then less than normal, so then you cannot correct platelets. So plasma removal is usually limited to 500 milliliter. This is the amount of plasma we can remove during correction of platelet apheresis. So, and sometimes we can even remove more than that. If someone is weighing more than 80 kilogram, which is around 175 pounds, each unit contains at least 3 times 10 power 11 platelets. So this is the unit of platelet single donor platelet bag. It should contain at least this number of platelets. And keep this one in mind. Don't forget that in each unit of platelet apheresis unit should contain at least 3.3 times 10 power 11. So testing is similar with other allogenic products. Of course, when we are correcting platelet apheresis, we have to test ABO for the patient, for the donor, ABO and the rhesus, antibody screening, infectious disease markers with repeated testing every 30 days for frequent donors. If the donation from one donation to another is less than 30 days, so we don't need to test for other things. Units with the visible red blood cell require a pilot sample for cross-matching. So that is usually practical in some areas, but in some areas also it is not practical to accompany platelet units with a pilot sample if there is a visible red blood cell in that platelet. Yeah, but usually unless there is a mistake, but during I've seen these machines how they work during correction of platelet apheresis. Usually, there's no possibility that the blood will be mixed with the RBC will be mixed with the platelet. Usually, the sample or that apheresis is very purely platelet and plasma. So, but if there is maybe any possibility that blood can contaminate it, so we can still use it, but we have to send a pilot sample from the same donor to the recipient in order to be cross-matched with the recipient blood, because you remember that platelets are not cross-matched. So without cross-matching, maybe those RBCs can cause problem in the donor, in the recipient. The second one is known as plasmapheresis. Plasmapheresis is a correction of source plasma. And what does it mean by source plasma? Source plasma is a plasma that is corrected before it is frozen. That is before 8 hours. It is known as a source plasma. So, and this source plasma can be used to prepare different other components. That's why it is known as a source plasma. And when it is frozen, after 8 hours, of course, it can be frozen. It is known as a fresh frozen plasma. So donors are classified as infrequent donor. Others are known as serial donors. So those who are called infrequent donors, those are the ones who donate plasma less than once in 4 weeks or less than once in a month. So, but those called serial donors, they donate plasma serially, which is more than 48 hours, more than twice a week. I mean, maximum, like always, they donate always, like more than 4 weeks, but they usually donate like maximum twice a week, and the distance between or the interval between one donation and the other should be at least 48 hours. So donor requirements are similar to allogenic whole blood donors. So if the patient is coming to donate plasmapheresis, of course, we have also to screen the patient, and the patient has to go through the same process as similar to whole blood donation. So serial donors have some additional requirements as well in order to protect them from excessive loss of RBC and plasma protein loss. So this should be always be noted and should be followed, because these people, they are known as serial donors. Serial donors means they are donating blood serially, or like frequently or continuously. So if they are donating blood continuously, so they are losing plasma protein, and we know we cannot afford to exhaust plasma protein from the donor. So we have to make sure that we consider testing their plasma protein always as they come to donate plasma. Loss of RBC, which exceed 25 milliliter during plasmapheresis or 200 milliliter per week. This is usually it usually requires what you call deferral, because if this person has lost blood, like for example 25 milliliter per every week as they donate, for example for the serial donors, or 200 milliliter in every 8 weeks as they donate, this requires 8 weeks of deferral. So serial donors undergo testing at the program start, and also every 4 months they also undergo testing. The special testing we're talking about include total serum and plasma protein, quantitative immunoglobulins, and the protein electrophoresis. This can be performed in order to ensure that their protein quantity is within normal limits. Donors with abnormal levels are always removed until values return to normal. Now, we have also what is known as leukapheresis. I think leukapheresis is the last one. Leukapheresis is the only effective method for collecting leukocytes, or granulocytes specifically. Leukocyte collection requires sedimenting agents like drugs to increase circulating granulocyte after informed consent. So we have to give informed consent to the donor that we are going to sediment or to bring or to detach marginating leukocytes on the blood vessels, because you know in our body we have 2 pools of mature vessels. One pool is marginating one, another pool is saturating pool. So some are busy, like, I mean, most of granulocytes are just marginating, ready to fight, you know, because they are ready, but a few of them are just circulating. So when you are going to correct leukocyte, correcting only circulating ones is not enough. So we have to give sedimenting agents in order to pull those ones that are marginating, and then you can correct them. So in fact, we have to give patient a sedimenting agent, of course, in order to mobilize them into blood. Each product must be tested for ABO and rhesus, and also human leukocyte antigen type always. So if contamination is suspected, similar to platelet, we have to attach a pilot tube. The pilot tube is like just a tube you collect in EDTA tube. It should be attached and should accompany the leukapheresis unit in order to be cross-matched with the patient blood. Now we have what you call a double RBC apheresis. This is when you want to correct 2 units of RBC via apheresis technique. Double apheresis corrects allogenic or autologous units. Donor must meet all blood requirements, of course. All blood requirements, you know, all the deferral processes, testing processes, and everything. This should be done for also double RBC apheresis. And what is double RBC apheresis? Yesterday, I think I talked about it. But the double RBC apheresis is correcting RBC apheresis 2 units at least from one patient at the same time. So the volume of RBC removed from the donor should not yield a donor hematocrit of less than 30% or hemoglobin of less than 10% after volume replacement. So this apheresis is in fact allogenic. So when you collect blood, make sure that you don't leave the patient with less than 30% hematocrit, so which means less than 10 grams per deciliter of hemoglobin. So, and this should be checked after volume replacement, which usually takes between 2 days and 3 days. Standard deferral is 16 weeks, of course, for double apheresis. You remember, single apheresis is 8 weeks, but double apheresis is 16 weeks with no platelets or plasma apheresis during this period. So during this period of deferral, the donor is not allowed to come and donate platelet or plasma during the deferral of double RBC apheresis. So if the loss is more than 200 milliliter, however, the donor may return 8 weeks without any problem. For example, this usually happens like a problem if the donor is donating blood, but before donation is complete, they stop it, and the loss was less than 200 milliliter. So this donor can donate within 8 hours. But if the loss was about 200 to 300 milliliter, so then it means that the patient requires, the donor requires 8 weeks of deferral. And if loss is more than 300 milliliter, this always mandates the full 16-week deferral program for this double RBC apheresis. So the 2 lines here, the 2 points here, is when the blood lost during apheresis. Of course, this is incomplete apheresis. If it is not complete, but already the blood was lost, so we have to consider all this protocol for deferral of that donor. Okay, now finally we have what is known as donor identification and aseptic technique. According to the American Association of Blood Banks, the standard requires that phlebotomist has to review the donor records and verify names and ID numbers for the donor, and the donor should state or spell their name for confirmation. So don't just ask the donor, your name is John or your name is Grace. You have to tell the patient, or to ask the donor to spell and state their name in order to confirm and compare with what you have. Labels are attached to the blood bags. Then donor record is performed and pilot sample is collected at this time. And also, of course, labeling of pilot tube should be done at this moment, because in most facilities, like in my country, we use the barcode to label all the bags, blood bags, donor records, papers, and also pilot samples. Pilot tubes are also labeled using a barcode, which indicates the donor name and donor registration number and everything. So blood collection sites are disinfected using iodine compounds or iodine povidone or povidone iodine or any other alternative, because some patients can be allergic to iodine povidone or povidone iodine. So the area must be scrubbed at least 4 centimeters around the sites for at least 30 seconds. The scrubbing should be continuous up to 30 seconds, and then this must be covered with a sterile gauze until this correction is complete. In most cases, we do it. Sometimes we don't do it, but it's a good practice. When you are correcting during correction, of course, you can cover that, because the patient, the donor is lying down, so the arm maybe is supported, maybe on the armrest of the chair. Sometimes we have to place it. This sterile gauze on that correcting site. Finally, we have corexidine gluconate, can also be used along with the isopropyl alcohol in case povidone iodine is sensitive for some donors who are allergic